Good morning. Good morning, everyone. Before we begin, can somebody pass me some coffee and a bagel, please? Um, can you guys hear me? Okay.
Yes, yes.
Okay. All right. So good morning. We have a very heavy agenda, and so why don't we begin the Customer Experience and Marketing Committee meeting Tuesday, June 9th. We're going to start with the adoption of the minutes. May I have a motion or questions regarding the minutes?
Motion.
Second.
Second.
So moved. Okay, action items. We're going to start with Tally Lager.
Yes, hi.
Hi, good morning.
Good morning. Should I jump into it or does does Valencia read the resolution?
Um,
usually
yeah, I don't have it up.
Yeah. Mhm.
Sorry. It's a resolution authorizing the executive director of MetroPlusHealth Plan to execute a best interest contract with Sutherland Healthcare Solutions to support the Gold Signature Experience for a total amount not to exceed 4.5 million, which includes a 10% contingency for a one-year contract term with two one-year renewal options.
MetroPlus is seeking a best interest contract with Sutherland Healthcare Solutions to support the Gold Signature Experience. Sutherland will provide a high-touch, personalized member support to MetroPlus's Gold and Gold Care lines of business, which provides coverage to New York City employees. The personalized support will span across benefits, claims, providers, and end-to-end healthcare navigation. This partnership is designed to deliver a differentiated member experience that is responsive, accessible, and easy to navigate. MetroPlus is seeking approval for a one-year contract with two one-year renewal options for a total contract authority of 4.5 million over the 3-year term. The authority includes a 10% annual contingency. MetroPlus conducted a request for information RFI in late 2024 to identify opportunities to enhance the Gold member experience. Based on RFI insights, MetroPlus launched a pilot with Sutherland to deliver enhanced personalized support to a subset of new Gold members during their first 90 days of enrollment. The pilot delivered strong results, demonstrating improved member engagement, satisfaction, and the value of high-touch support. MetroPlus now seeks to scale this model, establishing a consistent, differentiated signature member experience. Gold and Gold Care lines of business are critical to the growth and future of MetroPlus. To maintain continuity of service, preserve institutional knowledge and training, and avoid costs associated with transitioning to a new vendor, MetroPlus does not anticipate issuing a new procurement at this time, provided that the vendor continues to demonstrate strong performance and deliver positive member outcomes. Annual renewals will allow for continued assessment of performance and competitiveness and will be exercised only if services continue to deliver measurable member benefits. The scope of service is a high-touch personalized support experience for the Gold and Gold Care member journey. They will do proactive member outreach and benefit education, personalized assistance across benefits, claims, provider access, and healthcare service, enable streamlined access to information, resources, and support, and coordinate member issue resolution. We want to ensure a timely end-to-end resolution for our member inquiries and service concerns to continue to drive a consistent, high-quality experience that improves satisfaction, engagement, and retention. The board approval request is seeking a one-year contract with two one-year options to renew. The total contract authority request is 4.5 million over the full through 3 years. The authority includes a 10% annual contingency to address potential changes in member volumes and service needs.
Okay, thank you. Any questions?
I have some questions, Valencia. One, we had the requests for information. Are we able to, were they the lowest cost vendor? Are we able to extrapolate to say that they would be still the lowest cost vendor if we were to have requests for proposals or something go out?
Yeah, so we did a request for information instead of a true RFP at that time because we were still building the structure of what this would look like as
Mhm.
sort of a pilot because it was more than just a call center engagement. This was supposed to be a true member experience journey. There were other proposers that came in. Sutherland actually was the most low cost.
Okay.
They also serviced the needs that we were looking for and also they're a pretty large vendor in the sense of they have other types of opportunities to work within and other programs that they can help us to craft if we want to expand what we're doing as it relates to that. And so in terms of currently, and even with the expansion, their costs remain in line with the market prices, but also they remain in line with, positions that even we are paying for here at Metro Plus. And they have been really great about taking on more work, learning and doing more of the trainings and learning more holistically of Metro Plus. And they haven't upcharged us for that either. So it's just about, additional training for the employees that they have and training the ones that they're onboarding for us.
Okay. My second question is about cost. It's, I guess, like $1.5 million a year. And I'm just wondering how we um, assess the financial benefit to us. It's good that we have two one-year options so we can assess what the impact is in terms of new members and retention of existing members. But I'm wondering how we decided that $1.5 million was a reasonable amount of money. How much do we pay for the pilot?
We we pay about if we in an annual basis it came out to about 300,000, but it was a very subset like it was a smaller pod, right? So right now we have four concierge service members. We're increasing the pod to 13 members, but that's not exactly how many will be on the calls. The way that they look at the traction of how to put in folks on the calls is on our member volumes of the day. And so on Monday and Tuesday, you may have more folks on the phones as opposed to, later in the week. We also have coverage for Saturday as well. In terms of estimating the price, and that's why we built in a 10% contingency. Again, we estimated based on the hourly fee, and that's what it is. It's truly just an hourly fee. And we also have a manager and a team lead that is added to this to support the operations of the pod. And manage the volume as well as also manage the feedback that we're getting. There's surveys that go out after we're measuring call replies. I believe it's called NPS. Yes, they're NPS surveys, and that's how we came up with what would manage for this two lines of business. That's how we came up with what this pod would look like, so that there's always somebody available. And that the members are getting the service that they need. The other part too that we had to contemplate is it's not just a 1 or 2 minute call. These calls run 10, 15 minutes, depending, they take them from end to end and get them to a resolution. So that also impacts, how long you're going to have someone on the phone and how you need a backup to have someone else on it. So we really just like measured it against what this pod would look like based on our membership calls and volume. And also just based on the results of the pilot of seeing how long calls are taking with members, their satisfaction rating, what the questions look like, and what kind of support they're going to have to provide.
So the pilot was only for new gold members, and now we're expanding to old gold members. So
how many people do you have and do you project having over the next year?
So I think, Roger, towards the end of the year, we're at around 36,000 right now. We want to get to 40 by the end of the year. And so we did the pilot just for the new members because they need the most support. We saw that it was well received, and so this is why we're expanding beyond to the entire population. The clear ROI, I think it will be hard to say this is the number. The one objective metric that we can give, and Lila, I'm looking at you, is we took this pot of work from our call center and we're moving it to Sutherland, which means that the services and the reps that provided that service in the call center are no longer needed because it's moved to Sutherland. Correct me if I'm wrong, out of the gate, we have not made an adjustment to the headcount in the call center because we want to see that this is working well. The pilot worked well, but now we're expanding. But as you can imagine, if we're saying we'll have, it's a little overstaffed to provide top-notch service, but nevertheless, as you can imagine, 13 people that we're paying for, it has to impact a few headcounts on the call center. So if you're asking about a hard ROI calculation, it will be ultimately, are there a few headcounts that we can remove from the call center because we have Sutherland, right? We're moving by the end of the year 40,000 lives, right, from the volume of the call center. What does it mean? So that will be the hard, clear calculation, which, correct me if I'm wrong, we haven't, right? Have we applied it yet or not?
We have not.
We have not yet.
But the gold staff members, the staff members that handle gold and gold care, they are used for other lines of business as well. So we would just have to measure how we could reduce staffing to balance out the call volumes coming in. But yes, to Talia's point.
Right, but ultimately, it's added up. It doesn't matter that somebody, does this and that and the other thing. We're calculating a full FTE, regardless whether they do only gold or other things. So this will come down the road once we see that Sutherland continues to perform as well as they have during the pilot. So that will be a clear ROI. And then the rest of it is softer, right?
Yeah.
We want to provide the best possible service to attract more gold members. That will be harder to calculate. If anybody here, me included, will say, well, because of Sutherland, we grew whatever, a percent higher than expected. That's not true because we're doing so much more. So I think the only thing we should be looking at, which is objective, is the headcount.
Okay.
But I'm sorry, Talia, wouldn't you want to look at retention also? If you're looking at that population, one of the main focuses is for Sutherland is to provide this concierge so that people will stay invested. So is it a way to isolate the gold population and look at the retention of that population in comparison to other populations that may not have the concierge service?
We could, Valencia, only that our retention rate is so high because this is employer-based, right? They can switch in and out whenever they want. It's only during open enrollment. And already our retention, even during the open fall transfer period, it's called for employers, it's in the 90s. So, I mean, I'm not complaining, but when you have
I'm sorry, you broke up when you were just making that statement. You said
it's in the 90s already. Our
the
retention is in the 90s.
okay.
So
Okay.
I'm not complaining about the fact that it's so high and we're doing so well. It's going to be very hard to measure. And obviously, we will be reporting on retention on gold anyway. We'll report on retention in all lines of business. But I think that delta will be hard to capture. In addition, we're introducing every year, including this year, massive improvements to the product. So how will we be able to say, well, it's because of those massive, value add improvements versus Sutherland? So you are right, and we will be looking and reporting at the metrics, but I don't know that we can specifically rely on those metrics.
That's fair. I guess the only way is if it produces a negative outcome, right? If you see that the population is switching, you could discern that, okay, maybe this is not value added to do what we're thinking. So it would be interesting to see. Yeah.
Yes, and 100%, we will be definitely looking at reporting.
Okay, any other questions?
A follow-up question. Are there evaluation metrics beyond ROI and retention that have been established so you can sort of see what is driving the outcome?
You want to talk about it?
And from a member experience perspective, we are employing, oh, sorry. We are employing NPS scores. So this is to evaluate the Sutherland calls afterwards, understanding what member retention is. Are they likely to recommend us moving forward? So we will be evaluating that. I'm also in the process of evaluating additional metrics that we would want to employ for this group to measure that signature level of service, right? Because it's not only the idea is that we would be more proactive in prompting questions that may be arising from members, especially we saw that we did that in the welcome experience. So the welcome call was the pilot. So what we did was just look to see how we can anticipate what members' needs are. So we're going to continue that piece. So how do we measure that and the impact of that? That's absolutely a key piece that we're going to be doing, measuring.
And I'll just piggyback on this. This is something that we offer to all members, but we will hyper focus on Gold and Sutherland. So one of the complaints is people do not see the provider they have used or want to use in the network. Right now, when you go on our portal or our member portal, you can actually recommend a new provider to be added to the network. We're not guaranteeing it because we have to negotiate, but this is something we take into contracting and then reach out to providers to see if we can negotiate and bring into contract. Sutherland, I see as hyper focusing on that issue. So if somebody as in the gold product is calling and saying, "I'm having an issue. I really want this provider," we really want to hyper focus on pushing into contracting and trying our absolute best to bring that provider into the network. Again, it's available across the board, but there's a lot more support to bring those additional providers if they're game and we can negotiate a reasonable contract terms, bring them into the network and really increase the experience for the gold members.
So Talia, before you exercise your next option, if you could just send an email or something saying, this is our experience over the last 10 months, and this is why we're going to move forward and exercise the next option.
Yeah.
That's it. Thank you.
You're muted, Valencia.
Sorry about that. Any other questions? If not, may I have a motion?
So moved.
May I have a second?
Second.
Okay, all in favor? Let's move forward. New business, Project Edge, Tomas. And if you could try to expedite your presentation, Tomas, so that we can get through all of the agenda. I know everyone is very interested in what's happening with Project Edge. So,
Of course, I'll be very quick. I like to open with why, because we look at Project Edge every day. You may look at Project Edge once a quarter. In short, our current platform is losing its support end of 27. We're the last customer, and any of the new mandates that come out, we are implementing them on our own rather than spreading the cost every plan using the tooling. Want to talk a little bit about where we are in the process and talk a little bit about some of the things that we've achieved. You know that we've been live on our first line of business, the split line of business, since December. The shift to our teams has been meaningful. I'll give you two examples. First example, on the claim side today, to look at how a claim is processed. This is the following sequence of keystrokes an associate must memorize. F12, Shift and F8, and then tab, tab, tab to look up at a specific fee that you're going to look at. In the new system, you click a button called Fees under the Pricers menu, which seems more intuitive to those of us who don't memorize keystrokes day in and day out. What it does, it enables the teams to focus on the outcomes, not the mechanics for navigating the systems. Another example I want to give came from the medical management side. Dr. Shah shared this during our town hall. One set of reports we give to our regulators every quarter is activities on the advanced care management or SNP members. Last quarter, we reported 12,000 advanced care management activities, calls, outreaches, connections with our members, which compares to 7,000 we reported over the previous quarters. What has changed is the system that we're using. It's the same team doing the same work in a new system that enables us to capture information with much greater granularity and therefore take credit for the great work that the team does day in and day out. So our early days in the system, we are seeing the potential of what it can bring to the plan. We can go to the next slide. Now, the hard message of the day is that we've decided to delay our go live for wave 2. We've decided to delay our go live for wave 2 for one simple reason, and that is quality. To scale it to 100 times as many members, our bar for quality is incredibly high. And we've not yet been confident in saying we'll be at that bar 90 days from now on. There's two drivers for this. The first is not every feature that is required to scale us 100-fold is available today. There's features tied to mass claim adjustments or letters for PCP changes that have not yet been released, and we need a robust test window to really shake out any potential issues with those key modules and functionalities. And then two, our overall testing efforts themselves are behind schedules. They're behind schedule because when we started, we faced a lot of environment shakeout type of issues, which inflated our initial defect rate and made it hard for us to execute the number of scenarios, test cases that we planned on an early basis. We are in the aggregate about 4 weeks behind in our overall testing schedule and are continuing to make progress to catch up. Go to the next slide. Our roadmap, what does this mean? What it means is that for wave 2, our go live has been pushed to Q4 of this year. We will announce a date in the near future, but we want to make sure that the date is based on quality metrics that will truly determine we'll be successful operating with the service that our customers expect. We're continuing to drive towards a January date for our Medicare and QHP BPAS launch, but that date has a high risk profile attached to it. One of the main drivers for that go live being a risk profile is that we have dependencies in a previous wave. When you think about the biggest dependency we have is around provider contract configuration. When you think about configuring provider reimbursement, you typically do it once across all lines of business, and that's how we're setting ourselves up. So there is a significant dependency between our BPAS wave and wave 2. Again, the teams are working to expedite, and much of the configuration is feasible, so we have a sufficient test window, but there is a fairly high risk profile with a January go live of the MA and QHP launch. After that, next year, we have our major final wave, which will bring the remaining lines of business onto our platform. Go to the next slide. I think this is a recap of the information shared early. Our new platforms look to be promising and show promising results of operations, and we've shifted the date for wave 2. A little bit about wave 2 and key metrics. This is a dive in, and again, very quick overview is when we look at next slide, please. System health metrics or implementation metrics, you look at how you're doing with scope. Are your requirements good? Are they changing? The answer is our requirements are pretty good. Our churn is relatively small. So we did a good job capturing requirements early. We did have a delay in terms of build completion with some of the features I highlighted earlier not being planned to be ready until July. Testing started rough early because of the environment stability issues. We've been able to catch up some, and we're continuing on track to move forward. Build quality, again, early on, we had a very high defect rate, partially because of the stabilization of the environment's not being stable. That has improved since, and we're seeing areas with significant overlap between waves. For example, Medicaid benefit versus the SNP benefit has a focused small number of deltas. The testing of those modules and those components looks very promising. If we go through next slide, please. Maybe we'll go to the last slide where we talk about the key risks and challenges. One, we're operating under a fixed timeline. Our system ends support at the end of 27, we have to get done in 27. This leaves us little room for error, both with this wave as well as future waves. We've made a number of pivots that had positive impact, but every time you make a pivot, there is a cost to be incurred. We pivoted to a new team at the beginning of this year where we brought on an implementation team directly reporting into MetroPlus rather than relying on an external consultancy. So we have to be mindful of all of the activities that we will incur over the next year and a half as we complete this implementation. Thank you. Any questions?
Just bringing it in-house, Tomasz. Are the cost savings and is it as efficient? Because you obviously had to train up to take on the work. How has that been going?
So maybe three distinct answers to it. One has been going extremely well. I think it's been going extremely well because we get to be in the driver's share of the program. And in terms of policies, in terms of governance, in terms of how we run the program, it's how we run the program. And that has been more effective than the previous ways of running the program. I can tell you any day of the week where we stand for every single of the 2,700 requirements the team has created. Are we in design? Are we in development? Are we testing it? How does it look from a testing outcome perspective? And it is a level of transparency and granularity and program health measurement that we've never had before. All of our processes are in effect and running well. We've brought in truly top-notch resources rather than whoever was available on the bench from a consultancy, and we're seeing much better outcomes. The other answer to your questions from a cost perspective, all in all, we didn't reduce the number of resources supporting us. In fact, we've probably increased the number of resources supporting us. And net, we're running about 30% cost savings on the original run rate that we would have had with the consultancy. So from my vantage point, it had a net positive effect in every one of the dimensions that we look at. It's more cost effective, we're getting a better outcome, and we are in the driver's chair.
Okay, thank you.
Tomasz, you may have provided this before, but at the next meeting, I would be interested in seeing all of the contractors associated with Project Edge and the total cost that would go out through 27 for the completion of the implementation. And I understand that there may be additional, but right now, as it stands, it would be interesting to seeing the total cost of making this transition.
Valencia, we're tracking that in our finance committee lane, so we can pull that out for you and give you a perspective of where we are with the forecasted versus actuals through the whole program, and then just in isolation of 26.
Perfect. Thank you. Okay, any other questions for Tomasz? All righty, let's move down to provider satisfaction. Lila?
Good morning.
Morning.
So every year we administer provider satisfaction surveys as a requirement for Medicaid. In 2025, we administered it in November and December of last year. We did have a higher response rate in 19%. We introduced outbound calls to reach the providers. That was new, and so that contributed to the higher response rate of 19% compared to 11.9% last year, the prior year, which was just snail mail and emails. Next slide. The overall results of the survey, we saw that MetroPlus, which was number 1 in 2024, slipped to number 2 in 2025, and Health First came out in the first position. You'll see the N in terms of the number of respondents. MetroPlus performance exceeds competitors in health plan call center domain, but there are opportunities to improve in the pharmacy, finance, and overall satisfaction. The overall satisfaction we saw did dip across the industry, and you could see that in the next slide. So you'll see here, and I believe if you look at 2024 to 2025, 2024 we did see a nice uptick And this has contributed to the fact that we sunsetted the claims call center. And so therefore the providers only had to go through one touch point, which was the general call center. So it provided a positive overall provider experience in 2024, and the scores reflect that. In 2025, we did see a dip across the industry, a significant dip actually, and we believe that this has contributed to the outbound phone calls that Press Ganey had performed, because now you had office managers picking up the phone. But in addition to that, we do think that there's an underlying dissatisfaction or concerns happening because of the policy shifts that we are seeing across the healthcare industry. So you could see it's pretty self-explanatory how we had a dip going down. And MetroPlus being at overall 91.4%, where the physician would recommend MetroPlus to other physician practices. But MetroPlus overall satisfaction was at 77.8 and it dipped to 50.1, where conversely Health First was at 72.8% and they dipped to 54.7. Next slide. From a composite summary, just to drill down a little bit further, you'll see the overall satisfaction and the areas for which we will be improving on. Finance issues, we are working closely with configuration and core team to work more expeditiously and putting quality controls to ensure that contracts are configured correctly and turned around sufficiently. You'll see that pharmacy, there was a little bit of a dip. We do believe that this is more of an educational piece where we have to let providers know that pharmacy is going to New York State and was carved out. The call center service staff is still remained, it's a bit of a dip there, but overall provider experience, we did see it go up from 77.7 to 78.4. So that was an area that did go up, and we can focus in a little bit on the next slide. So these are the contributors that increase the provider experience with MetroPlus. As I mentioned, the call center exceeds our competitors. When you see how often are your issues resolved in the first call, it did an uptick to 50 percentile. Overall satisfaction with the health plan call center, it was at 75.5 last year, but it's at 74.4, so a slight dip. Next slide. And then the other experience is satisfaction provider orientation process, where we onboard our providers. You'll see a slight uptick. We really worked on our provider newsletters, communications, bulletins, and sharing information out to our providers. And so that is reflected, it's stable. Finding information on our MetroPlus provider website, stable, slight uptick. And then experience with using the provider portal, we saw a downward trend. We do understand and recognize that there is opportunity to continue to improve the provider portal that we are continuously addressing. Next slide. From a demographic segment standpoint, MetroPlus is strong for provider offices that have a larger volume of managed care patients. At 62.4%. When you look at our competitors, I think this is where MetroPlus is the strongest. Where we do have opportunities for improvement and focusing on is the smaller practices. And so we are being mindful of our provider relationship and managing their expectations and resolving claim issues or other needs that they may have. Next slide.
Okay, great. Any questions for Lila? Great. Thank you, Lila. Lauren, you're up next.
Hi, good morning, Valencia.
Good
So
morning.
our membership as of May 2026 is standing at 664,000 lives, which is steady to forecast. We are deviating about 2% at this point from our anticipated value for May. Some of the lines of business are contributing to better performance through May, which it does include our essential plan, QHP, Gold, and MAP lines of business. Through the remainder of this year, we do anticipate the membership to continue to decline given the pressures of our region to end the year about 648,000 overall lives.
I have a question for Mark.
Oh, sure.
What are you hearing in the community? What are you hearing about how hard it is to enroll, how hard it is to stay covered. What are you hearing about MetroPlus? What are you hearing about others? Just curious.
Well,
Sorry, lots of questions.
no, that's all right. Typically, nothing is really being raved about. I mean, that topic isn't something that comes up all the time, but it does seem like, because I actually start conversations regarding that. I always sort of sometimes just push something towards where I can get a little more information about what my friends or other people are thinking. But it seems like there's a lot of opportunity for people to still make decisions and reach out. And I wouldn't say people are generally lazy about that, but picking a healthcare provider for a lot of people that I'm around, it seems to be not something they give a lot of thought to. And what I mean by that is, uh, I think it's all revolves around how they engage in the advertising that you're doing, however simple they can see a message and it interacts with their brain and they process, Metro Plus, it's a nonprofit, or Emblem Health, it's this, or I I see they just want it to be, they don't even want to think about it. They want it to be easy because I don't want to say they're lazy, but they have other things they think about. And I think for healthcare, uh, they just want to have it and get that off their bucket list.
Yeah.
Um, I don't know if I'm helping any.
No, and I've been thinking about this. There's a massive, right? There's a massive change coming up in about 2 weeks. 500,000 people losing their coverage. We got our list, over 31,000 Metro Plus members are losing their coverage. I would think that the call center will be exploding. You would think it would be exploding, and it's not. It's I so I this is what we're seeing, and it's baffling to us, but I think Mark is right. We're like, oh my God, the sky is falling. Yeah.
You know,
I don't think members know.
Yeah, how do
Like,
they
would
tell them?
How would they know? Have they gotten a letter that they
Yes, yeah, yeah.
I sat at this table and I'm often amazed at everyone, all the intelligent things they bring up. But one time you all talked about the essence of Metro Plus and you used the word nonprofit quite frequently. I think that word is a gold mine of easing people into the bigger picture of just checking off healthcare on their bucket list, because when people they think all healthcare companies are out to rip them off and provide terrible coverage, but I don't mean nothing
No,
personal.
that's yeah, that's a
Uh,
sentiment.
uh, the word nonprofit, I think, is something everybody understands, and it's a really easy, happy word that people can connect with, trust, and where are we going to go? Well, this is a nonprofit. Maybe they're all nonprofits. They're not, but I mean that will direct people into wanting a safe place to go to weather the storm. And I think that's all they want, is to just check off, I want Metro Plus, I want to weather the storm. They're a nonprofit, and that, you know,
If I can just add from like my experience working in the clinic and my own personal experience, I was a nurse midwife who worked in FQHC for 10 years in the South Bronx. I think sort of when we're talking about the gold benefits about getting to your provider, in a way, I think the like insurance for most people, like the best way is that it's totally invisible.
Yeah.
Like it's just like
Yeah.
we're here and like this is everybody's lives here, but like
Yeah.
the best experience is like you never have to think about it. You get to see your doctor, it's covered, you get to see who they send you to, you get your meds, and you never have to think about it. The worst experience is you got to make 100 calls to get approval, you get denied. That, like, when it actually becomes present, That's the problem. So the more it can be seamless for the member, I think the better it's going to be.
I'm looking at Natasha here at the end of the table because that's a really, really good way to think and communicate about it.
Yeah.
Like,
We've spent a lot of time over the years really focusing on the not-for-profit, for New Yorkers by New Yorkers. And we thought, well, this year we want to really focus and be a little bit more transactional and be more about the benefits and less about the not-for-profit, because we know from a brand and awareness perspective, people know who MPH is. But I think that like it being invisible, like that piece of it is really important, that you just don't have to think about it. It just works
Yeah.
perfectly, and then it's one less worry that I could just sort of put off
One
to
less
the
thing on
side.
your plate,
Yeah.
right?
Yeah.
Yeah.
One less obstacle. It's just you get
Yeah.
your health care, no barriers. And in a way, I think we want to be like, look at us. But actually, most people don't care about insurance except when it's
Yeah.
a block for them
Yeah.
getting the care that they need.
And I think that some of our main point strategy here, right, is that is changing as we move forward with the federal agenda, where we will be interacting with our members more frequently, because retention is where our lives are right now. The base of the populations of, on insurance programs in New York has been, stable or coming down. And so the population and the retention so that they can continue their healthcare journey is now paramount. And so we have been thinking about varying, field initiatives to make sure these members are continuing essentially seamlessly, but helping them shepherd along the way.
The 30,000 members, we don't have anything we can send out to them saying, you're going to lose your health insurance. Here's what your option is, because we're not their option. I'm not sure what their option is. Maybe New York Cares, but that's a whole other procedure and process. So I'm just trying to think of a way of how do we communicate with them in a way that's helpful in directing them to a solution, because to say you're going to lose your health plan and not offer some direction wouldn't be helpful.
Yeah, so when we got the list from the state identified what alternative they can qualify for.
I see. In their letter?
So, no, not in their letter, in the document that the plans got.
Oh,
So each
okay.
plan got, these are the members, and this is the alternative. The absolute majority, the alternative is QHP. There are a few who qualify now for Medicaid because circumstances change, right? A few who qualify for other EP levels, probably a few that will go to and get employer coverage,
Mhm.
and the absolute majority is QHP. The problem is it's not
Expensive.
affordable.
Yeah.
Now, what we're doing is we run the data to see out of the 31 who is currently receiving significant medical care, cancer, right, HIV, like meaningful stuff, right? Like you snap your fingers and suddenly, oh, what are you gonna do? So we have a list, correct me if I'm 3,500. So a little over 10% of the 31 were identified by, a quick algorithm that we developed saying, these people, we need to handhold them because this is not just insurance for in case, they are in active treatment. And once the coverage goes away, there is potential for meaningful harm.
Mhm.
So what we are doing is we're focusing on the specific group because the harm is pretty apparent, and working with NYC Care to see what can be done. And so they will be obviously screened to see if they can qualify. So you're right, we can flag for them what they could qualify for with the understanding that in all likelihood they will not take that option. Some might, right? If you're in cancer treatment, I mean, some might, and the rest who absolutely cannot, we will focus on this population. We can't, you're right, we can't support all 31,000, but we can help with the ones that we're worried about the
That's
most.
a terrific idea. Really terrific idea.
I'm sorry, the 31K being kicked off, that's because the income levels have changed?
Yeah,
The
EP
state,
five.
the state gave a new level, and so they're
Right, the last Right, their last expansion for the 200 to 250 FPL
Yeah.
is being removed so that they can continue the coverage for EP 1 through 4 under the original basic health plan option.
Not the state, it's the federal.
Yes,
yes,
They
yes.
had to adjust.
Yes.
I understand. Thank you.
Okay, great conversation. But I was thinking about what you said, Talia, and what history has shown is that your call center will blow up when their care is terminated, right? And that's a little after the fact, but access is the key. So when those individuals attempt to access services and there's no longer coverage, that's when you will get the phone calls. That seems to be what has happened in the past with the state when there have been changes. It's like they don't believe that it's happening, and then it happens. Okay. I think, Lila, were you done? I mean, I'm sorry, Lauren.
Yes, this slide just shows that, proportionately to the base of eligible members in these lines of business, Metro Plus is maintaining our market share. There is a little bit of slippage in the Child Health Plus program, but across all of the other lines, we're, essentially holding. So to forecast, maintaining our assumptions. So from the financial perspective, things are carrying forward. That's next slide. And then, Talia.
Okay. Did Talia leave?
I left the
Oh, okay. I didn't see you.
I'm here. In the interest of time, I think we know about a lot of the issues that our membership is facing. So we're gonna go just really quickly. We obviously forecast the membership at the end of 25. We're trying to predict the future. It's pretty much impossible at this point. But you see that we are behind compared to our forecast. We're about 2% behind. A lot of it is we're behind on Medicaid, we're behind on CHIP. Those are the meaningful ones that we're behind on. And again, I think the reasons are well known. Next slide. We are doing, we stabilized on our research. There've been, we had fluctuations based on the volume, based on the percent of people who are in HRA versus NISO. So all of this is impacting. I'm just gonna say, I wanna go to the slide where I'm talking about what are we doing to help our members and to help ourselves. So this is what we're already doing, and we have been doing phone calls, text, mailing, email, vans, community offices, spreading our retention folks into the H&H hospitals. All of this is already in place and has been in place for a while. Go to the next slide. This is what we are now improving because there is an attack on our members. I'm not gonna sugarcoat it in any other way. There's an attack. The federal government is not interested in helping poor people. Helping immigrants and helping poor people is just against the agenda of the federal government. And so, on the other hand, New York is trying to do its best to protect health coverage. And obviously, this is why we are here and why we exist. So, there are a few things we're doing to improve our own operation and help our members. The first one is we're reaching out to all of our members, but certain members need to be reached out with more intensity. We just signed a contract with a third-party vendor who will help us to prioritize our more intense outreach in a more intelligent manner. They have access to consumer data that we do not have. They have additional feeds. So they take all of our feeds, measured with their feeds that they have, that they purchase, and then have an algorithm that they put together with all of those additional data feeds to identify who is the least likely to recertify on their own and needs additional outreach. So the contract is signed, we're working on implementation. We're constantly understanding through surveys, through outreach, through focus groups, et cetera, where are the pain points? A lot of the pain points tend to be waiting for an appointment, access. So this is why we're constantly working on our network, and we had some meaningful wins this year. We're talking about really the way we communicated that quality is everybody's business. We have been communicating that retention is everybody's business in the company, but now we put some processes in place. So it's not just a statement, there's a process. So for example, the care managers, when they're working with our members, they look at the recert rate, and if the member is due to recertify, they would transfer them. We're talking to the sales department. They do their own research, but if it's not under their purview and they see that somebody needs support, there's a direct line into retention. So not just talking, but actually building the connections between other areas into retention to support retention. We did a quick back of napkin, seeing that we're 2% behind. 2% is a low number. It's meaningful in terms of absolute numbers. Back of a napkin, we could afford to do this for this year. I just approved 15 additional temps to help with the outreach. Again, Mark mentioned that it's not a conversation yet, but Valencia, to your point, it will be once they will be denied care. What are we going to do? How are we going to be working with those people? At this point, it's brute force. It's nothing sophisticated. There are no algorithms, there are no AI. It's brute force to have as many people outreaching and addressing any barriers that people might have. The other thing that we've seen is retention owned, the retention department owned the retention across all the products. Only that there are certain products where we have more challenges, such as in HARP with seriously mentally ill individuals, such as HIV SNP, where there's a lot of skepticism and some apprehension about working with people that they do not know. So what we have done now, it's in process of being implemented, is putting people who are certified enrollers in those areas. So somebody who already knows how to work with mentally ill individuals can now also recertify them. Somebody who is advising somebody with HIV on a regular basis can now also recertify them. So it is a more tailored approach to the specific populations in terms of retaining them, because the retention rates in those populations is particularly low. And also a lot of them go through HRA, and so the whole process is more convoluted. So not only that there are inherent barriers, the process is also more complex. Why not? So it's a compounded problem. So we understand that, and instead of saying, well, we're going to try harder and do the same thing again, we essentially, to some extent, delegated the outreach. The text, the mail, the mailers, all of that still goes from retention, but the personalized outreach is now done by people who work in those areas. We also just hired somebody who exclusively focused on community-based organization relationships. So many of those organizations have enrollers, and obviously they enroll into various plans, including ours. We always obviously worked with CBOs. We didn't ignore them, but we need a more intentional effort and more focus on working with those CBOs so that we have better success rate. So the person just started 2 weeks ago. She'll have a small team. She'll have some people from marketing supporting her as well. But we have now a dedicated lane to working with CBOs and the navigators and enrollers that they have to enroll in the community. And then lastly, we identified that we have suboptimal management tools in terms of how we manage our workforce in retention, how we oversee productivity, how we rebalance the load between the different teams. So there's a collaboration now between retention and analytics to create a more robust, more accurate, and more nimble tools that we already have in the company and currently is already used in other areas of the company to apply to retention, so we get the most, if you will, bang for our buck in retention and maximize our outreach to our members. So that's very quickly, in a nutshell, what we're doing to help and improve our retention numbers.
Great.
And what will the 15 members, 15 new temporary staff as well as your existing staff, what is their message going to be?
So these are more focused on other reasons for disenrollment. So we have the research, right, which is just eligibility, but there are other reasons for disenrollment. So, there's a small portion, but for premiums, there's a small portion around people who are just dissatisfied. There are some people who own some documents. There are all kind of other reasons. So we want our permanent staff to be focused on the research, on the eligibility, and the temp staff to be focused on all the other reasons that people disenroll.
So in the past, when we did the disenrollment analysis, we did see a good chance of saving involuntary disenrollments outside of recertification. And so that's what they would focus in on. But I also just want to piggyback what Talia had mentioned about immersing ourselves with the CBOs, but we're also immersing ourselves with our provider community and just really strengthening our partnership with select providers and helping them maintain their patients because they do not want to see an uptick in their uninsured population as well. So they have a vested interest to be a strong partnership with MetroPlus. And then in addition to that, it's been 12 months practically where the auto renewal had sunsetted last year. And what we did see was that the large portion of the SSI population, which we had started to see bleed off in May of last year to this year, a large portion of those SSI population that no longer auto renewed were actually not eligible for Medicaid. We saw a high volume of disenrollments. But what's good is that we are seeing that normalize. And in the month of February, we did hit 81%, and in March we hit 80%. And in March we're hitting an 80% retention rate. So we are seeing that SSI population normalize because everyone else already fell off the rolls. But unfortunately, because of the impending July mandates where EP will go away, as well as the children from the ages of 0 to 6, the waiver was in place so that they would maintain continuous coverage. That goes away in July of 2026 as well. So we have to educate our members that if they have children who are up for recertification in July and thereafter, that they also have to renew to maintain coverage. So, although we stabilize from the auto renewal standpoint, we still have to pay attention to all the other policy shifts that are changing. As well as just getting the community involved, providers involved, and everybody within the organization involved to do retention sort of plan for 2027.
Yeah, I mean, the next 6 months, it's going to be all about strategy of how we're going to help our members because although they're being hit right now, 27 is going to be significantly worse with the volunteer work requirements, with the twice a year renewals, obviously the auto eligibility for kids. It was supposed to go away in March of 27. Instead, it's going away in 2.5 weeks. I mean, there is attack on membership, seriously. So the next few months are all going to be how are we going to prepare ourselves? What are others doing? What is the state doing? What are other states doing? And how can we minimize the loss of coverage?
Can I just build on that and just say that from the work that I do with other states and also my personal experience as a provider, I guess I cannot stress enough I think the value of working with providers and CBOs, like letters, calls, whatever to members. Again, I don't know if you have any data on like what that does.
We do. It's
I
low.
bet you it's really small.
Yeah.
Like just think of yourselves, how much of your mail do you read? Like how many emails do you get? When you have we have a person in a clinic or an office who you can talk to, who'll explain to you, or you have a front desk person, or as a former provider, I used to say to people, and I think I was unusual, like, oh, you make sure you re-enroll or make sure you do this, or you're like, I want to see you next time, right? And like people would listen. So any strategy where you can get people in offices and personal relationships and get the message to providers and their front desk staff, like about what is happening, I think is where to put your focus.
You're right. I mean, you're right. We have tens of thousands
I
of
know.
I'm sure
it's not a new idea.
No. But to your point, what we have done, we identified what we call tier 1 providers. which is the most important providers with the highest volume, who we can potentially work with. And each operational executive, me included, was assigned one of those tier one providers. And our roles as executives is to work with those tier one providers and make sure that their retention rates are improving, as well as other factors. But the focus is retention. The reason I'm presenting retention is now that our deputy CEO departed for a new opportunity, I took it on because this is how important this is. This is why I'm talking about it. I mean, I hope everybody knows in the company, our two priorities for the entire company, health, edge, and retention.
Yeah.
That's it. That's what I say. You get into the elevator, somebody asks you, what are you doing? Health, edge, and retention. That's it. Don't want to hear it. Not that other things are not happening. Obviously they are, but those are the top priorities. So you are right. It's just a lot of hard work. Roger, I mean, for the account that I assigned myself to, Roger had to work with their 13 different locations to make sure that they know which sales representative is showing up for retention every week, who to contact, and that's what it takes. But multiply that by thousands.
Yeah.
But we hear you. I mean, from what Mark is saying and from what we're saying, until it hits people, they just don't understand. And the way the state is communicating, it's almost, I don't know that, I think they're very focused on the regulatory aspect. They are not focused at all. I apologize, Valencia, for saying that. They're not focused on this being
The messaging.
understandable.
Yeah, yeah.
And urgent.
Yes,
And-
and urgent.
Yeah.
But so members are gonna find out when they show up to the doctor,
Yeah.
right?
And
They're
the
gonna be there, they're gonna
providers-
say like, your Medicaid's cut off. They're gonna say, what? That's the moment it's gonna happen.
Right.
And then the providers are gonna be like, wait, what are, like, are the front desk staff, what do we do? Why is this happening? Let me find, you know.
Providers are engaged, they are concerned, and usually the plans are champions of their own, but this time we are hearing, collaboration from the providers because they are just as, impacted downstream. So we want clear communication from the state about a multitude of things.
Okay, great conversation. Can we move forward with the call center stats and the new QHP and EP requirements? We sort of touched on some of them, but Lila, you could walk us
sure.
through that.
Yep, the call volume continues in 2026 to be lower than in prior years. This is due to improved self-service options that are available, lower membership, but we're also able to optimize our staffing model so that when calls are coming on the member line and we see an uptick on the provider line, we're able to shift members because we did see an uptick on our provider line. So pretty stable. If you move to the next slide. The call abandonment rate in 2026 was at 5%. It's around 5%, significantly lower in January, 6.9% when you compare to the prior years. We did see open plan year calls coming in. We had an issue with our members' flex cards. And then also we had to balance out the uptick of provider calls coming in and making sure that the provider abandonment rate was within reason to the best of our ability. Next slide. From a provider call line, you'll see that we did see a surge of providers calling us compared to the year before. This was contributed to number one, supporting the migration of Power Step into HRP for our first product line, which impacted us purposely holding the EDI claims from coming in and loading. And then we went ahead and started releasing those EDI claims files at the end of December, early January. But because providers got so used to receiving payments within 30 days or 15 to 30 days once we received payment, because that was an area that we improved on in 2025, they were calling because they were like, where's our payment? Because it was a little bit delayed. But that was all resolved. We also saw a few configuration issues that we had to resolve with our providers and some system issues. Interestingly enough, we also saw an uptick in artificial calls. I think last month we got 5,000 bot calls that are coming in. And so we're working with IT to identify them. And we're kind of creating some strategies to mitigate those artificial calls from coming in and using resources to answer them. So next slide. So in regards to our abandonment rate, again, because of the surge that we saw on the provider line, because of all the nuances I just mentioned, our abandonment rate is not where we would like it to be. We would like it to be closer to 10%, which we were able to maintain in 2025, which is the purple line. So the green line, we are actually starting to see it normalize in the second quarter. Next slide. So from a quality perspective, our NPS scores have been really well. The green box is our Medicare NPS score. It's 83 for the month of March, which is the highest we've ever achieved, which is great because of Medicare cap scores, Medicare caps being administered at this time. So hopefully we will see the benefits of that through Medicare caps. And then in terms of our CSAT employee rating, because as we know, if we have happy employees, it would parlay to our members. And so we are seeing a high CSAT rate.
Sorry, NPS, I just
Yeah.
don't know what that term means.
It is Net Promoter Score. It's members who would promote the plan versus detract from the
Who
plan.
would recommend
Who
it?
would recommend, who had a positive experience.
Thank you.
Next slide. So from what's new for 2026 is that the Department of Health is requiring health plans that offer the EP and QHP product lines to start submitting a call center performance report on a quarterly basis. This is new for MetroPlus. They are expecting us to meet a minimum of 30 seconds average speed to answer, a 5% or less abandonment rate for incoming calls, and the performance measurements would be based on calls offered, calls answered, and average handle time. We did inquire with the state if that means to meet the minimum 30-second ASA or average speed to answer is at 80%, which is what is a requirement for Medicare. They did come back saying it's 100%. So we are looking into that because we do think that that may not be reasonable. So next slide. So if plans fail to achieve the call requirements, meaning picking up the phone within 30 seconds of coming in or an abandonment rate of 5%, we do have to submit root cause and a corrective action plan to ensure that we meet those requirements. And then plans can earn up to 2.5% bonus points potentially within the EP Quality Incentive Program. So we are working with compliance to have this completed. We are working with some of our data. And we're trying to meet those requirements. Next slide.
Valencia, do you want to keep going?
Sure.
Hi, Valencia. Good morning.
Good morning.
So I'm going to go, if we can go to the next slide, I'm going to be talking through our gold member journey and some of the enhancements that we've done. As we had great fruitful discussion, we are facing a lot of headwinds, right, in the company. And so one of the big things that we anticipated are those headwinds. So to offset that, we really wanted to ensure that our gold product was able to offer almost a differentiating level of service and benefits so that we continue to grow our gold membership. The slide that we're looking at is really looking at not only the enrollment piece, so we know our members do need a higher level of service in the very beginning so that they understand, how to get their ID card, how to access their benefits, get their provider that they want, but also it's the engagement piece, right? Making sure that they understand what their benefits are so that they can utilize them. And then obviously we want to stay at top of mind when they have their decision to renew and stay with us. So as we talked about earlier, we did employ a welcome call that resonated very well with a gold membership. So we are extending that, obviously, as we talk through the signature concierge level of service, so that during the retention period, if there's any of those questions that come up, we can continue to engage the member. There's also, we did a lot of research to inform some of the different ways that we need to engage our member. So obviously provider access is a piece that we want to ensure that is not a challenge for our members. And we had some of those discussions here earlier as well. So ensuring that our concierge level of service can also address any access provider questions. So we can move forward to the next slide. So this slide, we did talk about the concierge level of service. So this is meant to obviously achieve that higher level proactive customer service and keep the member engaged. And candidly, also, we may find that we need to educate our members. Health literacy is obviously something that is always a challenge. So all of the services, all of the materials that are supporting the concierge, the signature service, will also ensure that we have materials that are health literacy, literate friendly. Sorry, awkward phrase, but I think you guys know what I'm trying to say. So all of that is encompassed within this signature concierge level of service. We can move forward. So some of the benefits that we are looking to expand. So the product team and many internal folks have worked very judiciously to understand what would actually be a market differentiator. So apart from service, there's obviously other pieces that we wanted to ensure our gold members were able to take advantage of. So lower cost. We see that zero copay urgent care is a big piece. We do understand that a lot of people utilize urgent care. We want them to, right? We don't want our members consistently utilizing the ER, but urgent care is oftentimes the PCP. I mean, to be frank, people do use urgent care as their PCP. So we want to ensure that our gold members do have that cost advantage. We remove that barrier to care. Obviously, the individual family rider reduction is also a piece where we want to decrease cost and ensure that our members are utilizing their benefits. Simplifying access, so no referrals for in-network specialists, that's already live. And we are communicating all of this to our members as well. We have added and expanded the low-cost drug access formulary. So that is also going live in July of 26. So that's another piece that we are communicating actively to our members to ensure that they can take advantage of this. Expanded support. So as we look at maternal health services, we know that doula services and having them in network is key for a lot of our maternal members. So we expanded that, and then we also added labor support. And then there's enhanced podiatry coverage. So 8 visits annually, and that obviously helps with our diabetic membership and other membership. So again, it's not only having these benefits, it's also how we communicate them to the member, right? Making sure they understand how to utilize them, where they can utilize them. So again, this also aligns with our signature concierge level of service, ensuring that folks understand that they have these benefits. So we want to encourage them to utilize them. Go to the next slide. So to support some of this and our retention efforts and candidly our member satisfaction efforts, we did employ a number of different initiatives. The most recent one was our CEO outreach. I'm not sure if folks heard of this in the field, but we did employ an SMS and email coming from Dr. Schwartz asking, basically thanking our members for their membership, but then also encouraging them to communicate with us. So what we did was internally, we had a support system so that if we did get responses, we would be able to rectify and help address any of the questions or issues or barriers that the member was facing. We did not receive very many emails in response. So I'm going to take that to say that we received 4 in total. I do believe that, a lack of response was actually a good response, right? Typically, folks do like to leave negative reviews and respond with negative experiences, so on and so forth. So we do think that this is something that is positively resonating, and we're going to continue to do this through the end of the year. We'll take stock and understand if this is something that's valuable for our members, and then we'll see if we're going to employ this continuously. So,
Okay.
Natasha, do you want to
Sure, I can take this. So we are in the process of redesigning our gold landing page. with new and fresh creative, new lifestyle photography, really strong messaging that's very much focused on benefits. It'll be clean and modern, and our our focus is really on conversion with very strong calls to action. When the page is finalized, we'll use this layout as a template for our other lines of business. Laura and I just met with Bellwether on Friday to review the updated designs. They've showed us round 2 of the design work. We gave them some feedback. We wanted a section on the page that would allow us to talk about like newsworthy updates, if there are additions to the network, if there are new benefits we want to talk to, we want sort of like a breaking news or news and newsworthy area. And then we also asked them to add an area of the page where we could really focus on testimonials for people who are enrolled in the Gold program and can talk a little about their personal experience. We are waiting for a staging link that we'll share with our cross-functional partners. And we are planning to do some A/B testing as well. All of the changes to the page are all based off of data, how people are currently engaging with the page, where they're clicking, where they're spending time, making sure that those areas that are the most engaged with are at the top of the page, and we're optimizing them. So we should have the staging link in a week or 2, and based off of feedback, we'll do about 2 or 3 weeks of testing, and then the page will go live this likely in July.
Next slide.
Just the first kind of question. Do you know what percentage of our users access the website through mobile phones rather than
70%
desktop?
do. Yes.
70% through mobile phones?
Yeah.
And does the mobile experience resemble this in a meaningful way?
So it will look like that, and but with some additions, because we also want to make sure that the scroll isn't too long on mobile as well, with some modifications, but it'll have the same look and feel. Yes.
Excellent.
Yeah.
Any other questions?
I just have a feeling that some of this is like too much, the words. Because a lot of I know, so when I get on the subway, I see our ads everywhere. So you have like one hanger's worth of time to communicate the message. And so, for example, the one that says $0 plan gold benefit members, and then has the page to the right of it with all of the details. Can you do more messaging in places where people have more time to read and less messaging where people are just getting on and off the subway? It's just a thought.
So this messaging is really for the website, where we know people are going to spend a little bit more time reading. And again, like we wanted to really highlight, like that's why it's so bold, the 0 and the 34,000 plus, which was going to change to tens of thousands. But so there's some edits already that we've provided to them, but this is really for the web page.
Okay.
Yeah. And we know that 80% of the traffic are newer prospective members who are coming to the site. So they really are looking for information.
Got it.
Yep.
Okay.
By the way, this seems great.
I'm sorry, is that Natasha speaking? Or
Yes.
Okay, are you going to go through the spring campaign? If you could briefly go through that now.
Sure. Did you have a
I was
question?
just gonna say the same. I think that goal, like $0, your gym is paid for, all these stuff, like that seems a great way to go, right? Yes, like.
Yeah, we really want to focus on the benefits piece of it and make it super easy to absorb.
I mean, I think we should just think about ourselves. I know none of us are on Medicaid, but like actually think about our own experience of like what we want. Right?
The spring campaign? Okay. Okay. Great. So I'm filling in for Laura today. So I'll walk you through the spring campaign. Thank you for having me. So the theme of our campaign is Life Made Easier. The campaign is really shifting messaging from functional benefits to emotional value, making it a little bit more relatable and connecting across audiences. So we're grouping the message in everyday moments, like bringing home groceries or covering essential items. And we want to highlight immediate tangible benefits, while also, focusing on how the essential plan can be used in other areas of our life, or where the ease and the value come. So we go to the next page. Here you go. Here's some of the creative for out of the home that you'll start to see. The subways actually went live. The subway advertising went live last week, so some of you may have already seen it. We've already gotten some really positive feedback on it. Bus shelters will go live this week in 60 locations in our top zip codes. We've got out-of-home advertising in convenience stores and beauty salons and laundromats. They'll all go live this week as well. About 20% of those locations will be in our Russian and Bengali zip codes or areas that we're focusing on. And really, this is to really, the strategy is that we want to be in the places that New Yorkers are frequenting regularly in their everyday lives. And we wanted to obviously make sure that the photography was new and fresh, but also showed a lot of diversity. And you'll see people are in the grocery store, they're, looking at, they're unpacking some of their essential items, and it feels bright and fresh, but also diverse.
We have a lot of veggies. I was on the subway and the whole wall of the subway was covered and every single thing had veggies. And I was like, what if you don't eat veggies?
Too much. That's good feedback. Okay. Okay, here's a new idea that we are trying this year. So we have identified Amazon lockers in 13 locations that are in our targeted zip codes for MetroPlusHealth. It's an 8-week program where we're wrapping the Amazon lockers in our advertising, our creative. There's an estimated 1.5 million impressions that'll come from that 8-week program. So 1.5 million people will see those lockers that are covered in MPH messaging. The program actually starts this week and it'll go through the second week of August. So this is something very new for us, but there are typically lines for these Amazon lockers in these neighborhoods where all of the deliveries get made and people, are frequenting them very often and are waiting in line to get the packages. So we'll see how this goes and we'll report back on the success there.
Can I make one quick comment? I know we're racing to the end here.
Yes.
These look amazing to me. There's one thing I would just say, and I realize they're not changeable, but I don't think everyone knows when they when they see MetroPlusHealth and Essential Plan, like that we're talking about health insurance. Like we know, but like the person on the street, like in a way, if it said like, did you know health insurance will pay for your groceries? Like very, very plain language.
Yeah.
Did you, the essential health insurance plan will pay for your, like, for me, if I was just someone on the street, like MetroPlusHealth, I think that's a clinic that I go to. I don't know. So I would just really try to step back or maybe get some people from the community to look at those and say, like, what do you think this is? Otherwise, they look beautiful. Like, great job.
That's a very.
For the phone
calls
Of course, it's like if I'd just be so curious if you went to the South Bronx and you were like, "What do you think this is selling you?" Like what you would hear.
That's such a good point.
Yeah, it's great feedback. Thank you. I know that they were tested, but yes, that's great feedback, and I'll take it back.
But when we're testing, do we say who that we are
that's the
testing?
thing.
Right. So
Like, don't
We're
tell them, like
for
what
what
is
they
this?
prefer,
Yeah.
but are we asking them like, do you know this is a health insurance?
Right. What is this? What is
Mhm.
what do you see this is selling you or
Great
that it's
feedback.
offering you?
Okay, thank you. I'll
Thank
take that
you.
back. Yeah, of course. Okay, so we do also have a Medicare campaign this year as well to drive total membership growth, and the strategy centers on a 3-pronged approach: acquisition, agent, and retention. So acquisition efforts are focused on expanding reach and visibility through a mix of paid media like TV and digital, social and YouTube, multilingual messaging, and sales support complemented by tools like a new e-guide that we've developed to convert interest into enrollment. And then we've got Agent, which is really designed to capture members as they're becoming eligible. Here we'll leverage direct mail, personalized touch points like birthday communications, and then enhanced digital journeys. And then retention, prioritizing strengthening engagement and long-term loyalty through a structured onboarding experience that really focuses on the first 90 days, but that is ongoing. And then this is just some examples of the creative for social and display. And then we're also working on a TV spot that'll air on New York One, Noticias, Telemundo, and Univision. And these are just some of the storyboards that we're working through as well. And those will the TV spots will air from September through November. And then here are some of the benefit call outs. So they're really focused on like $0 copay, the network, urgent care and telehealth, and then the up to $2,000 and over and OTC benefits.
To support retention.
Wait, Roger. You're on mute.
Okay, Roger, you can go ahead. I'm sorry. Saying something, but never mind.
As Dr. Schwartz was mentioning earlier, to support retention and acquisition of new members, the Growth Division recently repurposed the Deputy Chief Growth Officer role to provide more direct operational sales support to our sales and business partners by creating 2 new positions, a Vice President of Sales Operations and a Senior Director of Business Development. You'll see those new positions in blue on the org chart towards the right. In addition to providing increased sales oversight, we added 2 senior director sales positions that will split the territory of the regions into 2. One will cover and oversee Bronx and Manhattan, and the other will cover Brooklyn, Staten Island, and Queens to give the additional teams and sales reps some additional sales oversight support. To remain competitive and to match the day-to-day functions and responsibilities, we upgraded the functional titles of the sales managers to sales directors. To put this into context, some regions have teams that, or regions that support 6 teams, 60 sales reps. So they needed that additional layer of leadership in order to support the work that they do. In alignment with our strategic goals and objectives related to member acquisition and retention, we already recruited, or we are actively recruiting account managers to support the Senior Director of Business Development. Those people will work closely with both the 2 new multicultural directors that we're hiring in the marketing department, so they work hand in hand to foster new relationships and partnerships with the Bengali, South Asian, and Russian populations, particularly in Queens, Brooklyn, and the Bronx. And we'll prioritize the Essential Plan, Medicare Advantage, CHIP, and Gold in that effort.
Great. Any questions for Roger or anything else that has been presented today? It's been a lot of information. Good information, though. Okay, if there are no further questions, we will adjourn the meeting. Thank you, everyone, for your presentations, and I will see you at the board meeting.
Thank you.
Thank you.
Okay, bye, everyone.
Bye.
Thank you.